cut you short. What? Mark? Can we have everybody back in the theater, please? We're about to begin. A little cold in here. That's the cancer. Yeah, I'm freezing. I don't know. Clock. Let me take this off. Welcome back, everyone. Our third presenter is Dr. Andrea Teague, a hematology oncology specialist with Christus St. Vincent Regional Cancer Center in Santa Fe and Vice President of Cancer Services for Christus Health. She is actively involved in clinical trial research and expanding services for cancer patients in northern New Mexico, and she will be covering updates in advanced and recurrent prostate cancer.
Well, thank you. Thank you, everyone, for having me here to come talk to you today. Thank you for the Prostate Cancer Support Association. I always enjoy being able to come out of the clinic and talk to patients. So I, again, very grateful for the opportunity to be here. So I'm going to kind of talk mostly about kind of the treatment landscape now for patients with either recurrent prostate cancer or more locally advanced prostate cancer, or if it comes back metastatic. And I will touch a little bit on PSMA. Dr. Franklin gave us a great overview about that. And then I think our next presenter will be doing a lot of the genetic talk. So at the end, I'll be talking a little bit about that as well, as many treatments are now focused on a lot of molecular and genetic changes that we're finding in prostate cancer. So, as a medical oncologist, it's always great through your career as you see kind of what advances have been made. And prostate cancer is no exception to that. I know for most patients and for physicians alike, we want more trials, more drugs, more quickly, of course, to help our patients. But we are making very great strides in combating prostate cancer. And I can't wait for the next 5 to 10 years to see what's going to be down the pipeline. So there have been a lot of changes, and so we'll be talking about that and how it's kind of changed how we think about prostate cancer and treating it, especially in the last 5 years. Yeah. Okay. So I'm going to do a little bit of updates in imaging just because it does affect, as Dr. Franklin said, what we used to do with CT scans and bone scans, having now the opportunity to use PSMA scans, it is helping us detect kind of more locally advanced disease at the start when we thought maybe it was less advanced. I'm going to just touch a little bit on that. We'll talk about updates in androgen deprivation therapy and novel hormone therapy, since that's the backbone for most of our prostate cancer treatments. We'll talk a little bit about updates in chemotherapy. We don't have a lot of changes in the drugs itself, but now it's more of combinations of medications that we're using with chemotherapy. Updates with the radionucleotide therapy, immunotherapy, and then targeted therapy. Okay. So prostate imaging has evolved over the last 2 decades. And we're trying to always get better pictures so we can better see cancer. Ideally, we want to find cancer before it even makes a tumor. And we're working on that too, finding better ways to detect it even outside of imaging. But the imaging has evolved over time. MRIs have greatly improved from the types of MRIs we do. Some more novel new MRI techniques out there are called restriction spectrum imaging to try, again, localize prostate cancers in the prostate itself better and more accurately. As Dr. Franklin kind of talked about, we have had bone scans and CT scans to look for distant metastatic disease, and those have been around for a very long time. And now we're getting to more of the more advanced radionucleotide PET scans. And the current one that we mostly are using is the PSMA PET scan. And again, the goal of this is to try to detect disease recurrences at lower PSA levels. And as Dr. Franklin talked about, it may be particularly beneficial for patients with high-risk disease at the time of their diagnosis to actually see if it isn't just locally advanced, but they may already have metastatic disease, as that can impact the type of treatment that we do. So this improved scans that we've had over the past few years are changing kind of our risk stratification, and we are seeing some changes in how we're classifying patients because of this. And then the theragnostic applications, again, if you've got a positive PSMA scan, that leaves for treatment options later down the road. So as I talked about, one of the newer techniques, and these are still mostly at academic centers where they're using restriction spectrum imaging as part of the MRI to look at the prostate itself. MRIs give great anatomical detail, and this kind of imaging can help urologists in particular when it comes to localizing where prostate cancers are, targeting biopsies at those areas to make sure we are getting the right biopsies at the right areas to try to especially find higher risk disease. So that is one of the techniques that are using, so it can again help improve the accuracy of the prostate cancer detection and progression, especially in the prostate, which then hopefully would translate to us being able to initiate treatment faster. So the conventional imaging that we've always done to look for metastatic disease have been the CT scan and bone scan. So when a new prostate cancer diagnosis is made and there's a certain concern that it may be higher risk disease or that it may have spread at the time of diagnosis based on high risk features such as Gleason scores or your PSA level, we often do the complete staging. And again, this used to be with the CT scan of the abdomen and pelvis and then a bone scan to look at all of those bones. That is the first place that prostate cancer often metastasizes to. So, we're still using them, but less and less. And I think as we get more data with PET scans and PSMA, or we find other ligands to use, the goal is again to get better, more accurate imaging. So PSMA scans, for the most part, have taken over for high-risk disease or at the time of recurrent disease or concern for recurrent disease. We don't really know how to use it in just surveillance type now for our prostate cancer patients who are just on maybe ADT. Insurance doesn't pay for it in those situations. We don't know if it'll be a benefit in that way until we start to get more and more information and collect that data down the road. So, these are what pictures look like. So for bone scans, you use the radioactive tracer that goes into a vein, and then it localizes to the bone, and this is the most common isotope used for the traditional bone scans. Again, and it localizes to bone in proportion to the areas of bone that are undergoing remodeling. And when does a bone undergo remodeling? Well, if there has been destruction of bone because of cancer growing there, your bone is always trying to repair itself and remodel. But it isn't very specific because there's other times that your bone is remodeling. and that is if you've had a fracture. Your bone is trying to repair itself. Infection can do it, so people who have osteomyelitis or infection. Even significant arthritis will show up in bone scans, and other bone diseases like called Paget's disease. So, the sensitivity of it, it's not as high as we would want it. We always want something ideally in the 90s or so that's very sensitive to detect it, and that we want it as specific as possible. So again, it's not so specific because other benign bone diseases can cause uptake on a bone scan. But it is widely available, and compared to a lot of our other imaging techniques, it is low cost. So, but the limitations of it is the image quality. As you can see here, it's hard to sometimes localize exactly what bone it is in. Challenges in interpreting results if it is due to a benign bone disease versus a cancer. We talked about the low sensitivity and or specificity for it as well. And one of the issues that we do have is, especially with lower PSAs, it is less sensitive at detecting likely recurrent prostate cancer, even if it's already in the bone. We do the CT scans because that can help look for lymph nodes and other organs and soft tissue. But again, the sensitivity and specificity for that, especially compared to our newer imaging modalities, is a lot lower. So again, all of the CT scans, bone scans, MRIs, we're still limited in detecting small amount of disease. By the time you see a tumor, already hundreds of thousands of cells, if not more. Obviously, we want to be able to try to detect things earlier, so we may be able to intervene earlier. So again, this is kind of why we're always looking for newer, better things, and that's been one of the reasons that we've been looking for the next generation imaging techniques. So PSMA PET scan, as Dr. Franklin talked about, has really been the next step in the evolution of our imaging, and helping to try to detect especially metastatic disease at an earlier time. It does offer superior image quality, interpretation, sensitivity, and specificity compared to just a CT scan and bone scan alone. And I won't go through all of this since, Dr. Franklin did such a great job for talking about what it is. Again, it's not 100% specific. It's found in other tissues like the salivary glands, the intestines, and kidneys. So you do get some non-specific uptake that you have to always take into consideration when reading these scans. But most prostate cancers have PSMA expression, and the higher the grade, the more aggressive ones tend to even express more, which is Dr. Franklin had talked about, correlated with a worse prognosis. So here's just to give you an example of kind of why this has become really what we want as the standard of care. So this is a patient who had had a CT scan and a bone scan that really didn't show much of anything, especially the bone scan, because he does have bone-only disease. And so when he did get the PSMA PET scan, which combined the CT scan along with the fused image of the PET image, you can see that he had metastatic prostate cancer in this area of the neck, which was not seen on previous bone scan. And so here's just another example of trying to localize prostate cancer and see where it is in people who are at higher risk. So again, the bone scan really did not show anything until they got the PET PSMA scan, which again fused the PET image with the CT scan. And you can see here that really the bone didn't look very abnormal, but when fused with the PET portion of this, it localized one area of disease into that bone that was not really seen on bone scan at all, and as well as this patient ended up having other areas of disease. So the So this was a trial looking head-to-head comparative studies in patients who had high-risk prostate cancer, investigating bone lesions, detection of conventional imaging versus the PSMA PET scan. And again, this is people who were diagnosed initially just high-risk disease, but unknown if they're metastatic at the time of diagnosis. And so, for example, in this, what they did is they looked at 79 patients. They had high-risk features. So they were initially staged just using, traditional imaging, and then staged also with a PSMA PET scan. And what they found, and so patients who presented with a bone scan that showed no metastasis on that traditional imaging, we called them group 1. And then patients with a bone scan showing low volume disease, so they had some metastasis in the bone, but nothing in any organs, represented group 2. And so what they saw, that there was a change of risk group in 12% of patients in group 1, meaning that 12% actually we changed the diagnosis based on the findings on the PET scan. And then in group 2, a change of risk was found in almost 2/3 of patients. Now, some patients were actually upstaged, meaning they found even more cancer compared to the other imaging, but also downstaged in 22%, meaning the bone scan showed something, but it wasn't active on the PET scan because it was just a benign bone problem. So we can really see it can change what the initial stage can be, either making it a higher stage or actually in some cases even a lower stage, which again can have significant treatment implications. So, staging, our initial staging is one of the most important things we do because that just helps determine what the next step is for treatment. So really it's just become, again, the standard now of using PSMA PET scans in patients who are considered high risk, so we can get the most accurate stage at least we can at this time. So that's kind of where we are now with high-risk disease and imaging. And so now I want to talk about, well, how are we treating these patients with locally advanced disease, and how has that changed over time? So androgen deprivation therapy, as you've heard and most of you probably know, is still the backbone of our treatment of using medication, rarely surgery anymore, to decrease the amount of testosterone in patients with prostate cancer. So these days, LHRH or GnRH agonists are the most widely used anti-deprivation therapy treatment when patients are diagnosed either with recurrent cancer after they've had, for example, radiation or a surgery, or if they have more locally advanced or metastatic disease at the time of presentation. And so as our first presenter talked about, what happens is our pituitary makes our brain in the hypothalamus makes a hormone called GnRH or LARH, and then it tells our pituitary to make basically start the cascade so we can, the body can then make the testosterone either from the testes or the adrenal gland that it needs. And now we have many ways of trying to find places that we can interrupt this pathway to shut down testosterone production. So the one that is most commonly used, and these are the leuprolides out there, or daguerreolex, is to give a medication that's going to block this. And so if you stop at the top here of this pathway and you shut this down, then the pituitary and then the testes and they don't get the stimulation that they need to make the testosterone. Now, some of the newer drugs out there that are now also commonly used affect the pathway in different places. And these are the new androgen receptor pathway inhibitors in kind of the second generation of anti-androgen therapy that we have out there, and these are mostly the pills that we're using these days. So these really are the ones that block how the androgen receptor gets into the cell to stimulate growth, and it blocks it here. So these are the medications that we'll be talking about: the enzolutamides, darolutamides, apalutamide. We have a whole host now. So that's where these drugs work. Abiraterone is a slightly different. It blocks an enzyme. So that works right here to block this, to decrease the production of the DHEA that is also necessary. So that's why these can work in conjunction with each other. That's why patients will get both the leuprolide as well as one of these medications, either abiraterone or the ones that block the androgen receptor here, because they work synergistically. Because they're working at different parts in the pathway, they work better together than either one just working alone. So when we have someone who has now metastatic castrate-sensitive prostate cancer, so meaning they're just newly diagnosed, they haven't had any treatment, or they've maybe recurred after treatment, but they haven't been on any hormone blockers, they haven't been on androgen deprivation. So in that case, we still consider them castrate-sensitive, meaning they should still respond to blocking those hormones. So initially, we used to just do the leuprolide alone before we had some of these newer drugs. And so that's where the biggest changes have happened over the last 5 to 10 years, is the development of these drugs. And now it's standard of care to give the androgen deprivation with leuprolide with one of these drugs. And the NCCN, which is the National Comprehensive Cancer Network, which kind of is the kind of blueprint for medical oncologists, and goes along with really what the best clinical practices are. So they develop these guidelines to help practitioners and patients know which are the best choices to use. So right now, the three, FDA-approved drugs and top-of-the-line NCCN guidelines are androgen deprivation therapy with one of these three drugs. Now, what we don't have, though, is great information about which one to choose. So with drug development, usually one drug company has one drug, another drug company has another drug, and so they're all trying to get to their drug approved, and it's all happening at the same time. So rarely do drug companies say, oh, I have a new drug, and I have a new drug, so let's compare them back to back. So we don't have a lot of comparison of ever one drug to another. Especially in the first few years when drugs get approved, that's always like the next step down the road. So we have these three drugs with not a lot of cross comparison, but there is some information. So these are listed as three choices. So patients always ask me, are like, well, which one do we choose? So what a lot of research are doing is now trying to use real world data. So let's say, okay, we've got a lot of patients out there. Physicians are choosing all three of these drugs. Let's start trying to gather some of that data to see if we can help figure it out. So this was an analysis, again, of looking at overall survival in patients with metastatic castrate-sensitive prostate cancer treated, in this case, either with apalutamide or abiraterone. And so there's always limitations to this type of data because it's all retrospective. You're kind of looking backwards. All patients are different, and you can't account for a lot of differences. But it does give us some clues and at least some information that we didn't have before. So in this study, 250 patients received apalutamide, and over 600 patients, so quite a large number of patients, received abiraterone. And then they looked at overall survival, like how were patients doing at 2 years, how many people were still alive in each group. And it did at least appear that maybe the apalutamide was having a benefit on overall survival compared to abiraterone. And they did note that between this, there was a 40% reduction of death in patients who were on apalutamide instead of abiraterone. So here was another study which was comparing systemic treatments for, again, metastatic castrate-sensitive prostate cancer. And this was a pretty large study, kind of pulling together a whole bunch of information to see if they can find something statistically significant to help guide us. And what they really showed is, most of these drugs, honestly, in the big scheme of things, are pretty similar and are effective. And teasing out, which one may be better, maybe prove a little bit challenging. So this, they looked at all of these different drugs, so abiraterone, apalutamide, and the enzalutamide, and then also docetaxel, the chemotherapy drug. And again, if you look at these lines, they're all bunching pretty close together. There's not a huge difference between them. So you've got, this is overall survival and this is progression-free survival. And, there's not a lot of difference that are between these. There's not a lot of space there between enzalutamide, apalutamide, and abiraterone. They all seem to be doing better than just chemotherapy alone, and of course have different side effects, but still better well tolerated. So that really then leads to a discussion with the patient. So most of us, what we do is talk about what are the side effects. All of the side effects of those drugs are a little bit different. And so we try to base our decisions on the patient in front of us, which one they think they may tolerate. But it turns out all three are pretty good. So if someone has a history of seizures, we don't like to use enzalutamide because that can get into the CNS and cause problems. So we kind of cross that off the list. Some of them cause more problems with blood pressure. So if my patient has a history of hypertension, I cut that off the list. So that's really now how we're trying to make our decisions for that situation. So the next line of treatment that usually that we consider is now if patients have metastatic cancer and they're still castrate sensitive. Again, before the development of these androgen receptor pathway inhibitors, the three drugs we just talked about, the standard of care used to be if you had already had, ADT, we would do ADT with docetaxel or Taxotere, especially if there was a lot of cancer. If patients had a really high burden of disease, we wanted to get control of it. So, that used to be our only option, but now with these new drugs, again, we've got a lot more choices of using ADT with one of these. Again, we're always trying to do things better now, and then once we developed these drugs, we then said, well, what if we combined the two? What if we said, okay, well, we know that now this works better, ADT with one of these. Well, what about all three? So if we take now ADT with a drug and add chemotherapy, what's the benefit of that? Because that's also now an opportunity that we have for patients with metastatic disease is to say, well, we can do just androgen deprivation, dual androgen deprivation, or we can consider adding chemotherapy to it. So what's the data for that? So one trial is called the PEACE-1 trial, and it combined leuprolide, docetaxel, and abiraterone. And what this showed that it did improve progression-free survival. So patients were living longer before their cancer came back, and it increased overall survival. But it did come with, obviously, a side effect of a modest increase in the side effects since you are getting cytotoxic chemotherapy with it. So in this trial, patients, so they had a lot of patients, and then they also adding some radiation with it as well. So again, in patients who received the abiraterone along with ADT and docetaxel versus those who didn't, had longer progression-free survival, and they hadn't even reached the overall survival yet, where the overall median overall survival of patients who didn't receive it was 4.43 years. Definitely more side effects, but it is something to consider. And usually, in talking to our patients, we consider that many factors before making this decision. A lot of it is overall your age or how well you're feeling. Do you have symptoms, and what is the burden of disease? So in this trial, this is the Arison's trial. And what this was looking along with was a newer drug called darolutamide to see if addition of darolutamide versus just a placebo increased overall survival. And so darolutamide is another one of our choices. If you go here, along with chemotherapy, besides abiraterone for patients who have castrate-sensitive prostate cancer and are now metastatic. And again, you can see that it was an improvement of overall survival when darolutamide was added. But of course, we don't have comparison of the two, of abiraterone versus darolutamide with a chemotherapy. So again, we have one of those two options. I don't know which one is better, and we just don't have that data. So again, which to choose? So this one big study looking at 10 randomized controlled clinical trials published this past year, they reported that triplet therapy with darolutamide plus docetaxel along with leuprolide offered the best overall survival among patients with metastatic castrate-sensitive prostate cancer, followed by this. So in looking, kind of pooling all of the data that they have out there, again, this is a meta-analysis, isn't looking forward, this is looking back. So there's always limitations to that. There is a possibility that darolutamide may be just a more effective drug, and we are seeing that in a little bit, and I think it's just the mechanism of action of those drugs, given where it affects that testosterone pathway, may be just a little bit more effective than abiraterone, which inhibits the enzyme to decrease the risk of testosterone production. Okay, so we have, just to kind of refresh everyone, we have a newly diagnosed metastatic castrate-sensitive prostate cancer. This is how I always kind of think about it. Is there a lot of cancer first? Is it high volume, low volume? And is it were metastasis present at the time of diagnosis, or was it due to a recurrence? So if there's a lot of disease right at the first time of diagnosis, I almost always try to do a triplet therapy if I think the patient can tolerate it, just because of the data I showed you. Obviously, if not, we can just do dual therapy or a clinical trial. If there's not a lot of cancer, there's only, maybe 2 spots in the bone, patient feels really good, we're very much focused on quality of life, I often consider just doing the dual therapy. There is data to suggest that once you treat on low volume disease and treat the metastasis, sometimes there's a benefit of still doing radiation to the prostate, the primary site of cancer. If it, again, high volume and recurrent disease, it just kind of depends what they've been on before, how long it's been in the time frame from initial diagnosis to the recurrence. Again, we will consider the triplet therapy versus just dual therapy. And then if it's recurrent and low volume, maybe previously only had ADT, or it's been a long time, maybe they never had it, we again just typically use the dual therapy. All right, so what about non-metastatic but castrate-resistant prostate cancer, meaning patient has had prostate cancer, they got some sort of treatment involving androgen deprivation, but they didn't get cured. It has yet spread anywhere. It's not metastatic, but we know there's cancer there, and now it's castrate resistance, meaning it is growing despite being on leuprolide. So again, in this situation, The development of those same 3 drugs are FDA approved in this situation. And again, which one do we choose? So again, this was another real-world use of these 3 drugs, darolutamide, enzalutamide, and apalutamide for non-metastatic castrate-resistant prostate cancer. And what they found is with these 3 drugs, this was their average follow-up, and this was, again, retrospective review, so it's looking backwards, not looking forward. But what we were looking for is to see when they recurred and when they were found to have, when they discontinue or found to have metastatic disease. And so they did try to compare, and a lot of, so trying to just kind of figure out the median time to this happening. And the best data, was for we have the darolutamide, the enzalutamide, and the apalutamide, and then the percentages here, 24%, 13%, and 12%. So again, a hint that at least maybe some of these newer drugs, particularly the darolutamide compared, were a little bit more effective. So, so that's what we consider if they've not had now. So that was the non-metastatic castrate resistant. Now what if they have metastatic castrate resistant? Again, now they've recurred, they've been on ADT, and then we get a scan, and unfortunately it's not just localized anymore, maybe to the prostate, but it has spread. So if they have not been on one of these drugs before, again, we try to do one of these 2. These are the ones that are FDA approved in this situation, or again, consider chemotherapy. In special circumstances, we do the radium-223 if they have maybe some symptomatic bone disease that we want to treat, and it's pretty much bone-only disease with no disease in any organs, or we can do some immunotherapy as well. But these more special circumstances, we tend not to use them routinely up front. And so for bone-only prostate cancer, and Dr. Franklin had touched on this, that radium-223 has been around for a while, and it has shown improvement in overall survival and time to first symptomatic skeletal event. So it is something to consider for patients who do have bone-only disease. It can be effective, and it's quite well tolerated. Now this is the immunotherapy. It's one of the first cancer kind of vaccines that we had. Prostate cancer was never really considered to be great at using immunotherapy. To be a good candidate for immunotherapy, you need a cancer that needs to look really ugly. It needs to look a lot different from a normal cell for our immune system to be able to recognize it as something it should destroy. And prostate cancer has never traditionally been one of those. Melanoma is our best example. Melanoma cells look terrible. You look under a microscope, they look ugly. They do not look like a normal melanocyte. Prostate cancers don't look that way. So the fact that they were able to develop this a while ago was pretty impressive. And what they do is they take out a person's, some of their immune cells, they stimulate it with a protein that hopefully our body will be able to recognize, grow up those cells in the lab, and then infuse it back into the patient. And now you kind of have primed your immune system to recognize cancer cells and fight it off. But it doesn't, it's not a huge benefit. The time to disease progression was really minimal. A little bit benefit of overall survival. But it is a challenging thing to do. You have to do leukapheresis, taking off your cells, growing them up, putting them back in. So this is, I don't say it's come out of favor, but it's a challenging drug to administer with not a lot of benefit, although I still do use it in certain situations. So, now again, we've got some of these radionucleotide therapies outside of the radium-223, which I'm not going to talk about much since Dr. Franklin did such a great job. But the options now for bone-only disease or progression after docetaxel is doing the PSMA therapeutic dose or the radium-223 if it's just symptomatic bone disease. So those are our options in that situation. And so this trial looked at, so now the question is, can we still use both of them? So as Dr. Franklin said, most of us now, we like the PSMA, it's very well tolerated. Well, we still have two options though. What happens if we're now using PSMA? Can we use radium? So a lot of the questions that we have now in treating our patients is sequencing. We're still trying to find out that. Some of it is dictated by just our trial information, like PSMA. We only can get it FDA approved, or we only can get it approved by insurance after docetaxel, since that was how it was studied in the trial. So, the newer trials are looking at moving this stuff around to trying to find better options. So this trial did look at the use of radium following, PSMA. Unfortunately, it was found to be safe. And the safety of it was pretty good, with not a lot of significant long-term consequences to it. So that was some good information to have there. The next thing we're trying to look at to better improve the treatment of our prostate cancer patients is now trying to find more targeted agents. And the way we're doing that is to look at germline and somatic mutations. So germline mutations are mutations you're born with. So many people know that there are certain mutations out there that increases your risk to developing a cancer in the first place. The most common ones people know about are like BRCA. BRCA 1 and 2 increase the risk of prostate, ovarian, breast, melanoma, and pancreatic cancers. And so what almost all of us now are doing, especially for patients with high-grade or early onset prostate cancer, is doing germline testing. So testing the patient itself, were they born with a reason? And then somatic testing means testing the tumor. We know the tumor independently gets its own mutations. That's how it turns into a cancer, from a normal prostate cancer cell into one that causes cancer. And so there's lots of mutations that we can find. Here's a list of the most common ones. I'm sorry that didn't show up very well. But these are all of the kind of mutations that we're looking for in germline mutations. Most of them are in DNA repair, that if you can't, your DNA gets damaged, like my skin cell gets damaged by the sun, and I can't repair that damage, I'm at a higher risk of getting cancer. So ATM, BRCAs, CHEK2s, and then ones, PALB2, these are some of the most common ones. And then in somatic, in the cancer cells itself, BRCA mutations, ATM, and these are also related to something called microsatellite instability, and we'll talk about that in a little bit. These have led to targeted treatments that we have for prostate cancer, the identification of these. So now if patients are found to have a BRCA mutation, we do have now drugs that help in this very specific situation. So olaparib and niraparib along with abiraterone. So again, now we're trying to add drugs together to say, are the two more effective in keeping people healthier for longer and keeping their cancer from growing. So in both of these cases, adding this drug, which helps patients with a BRCA mutation, is increasing overall survival. And this is if they've had no prior treatment, if they have had a prior androgen receptor pathway inhibitor, but no prior chemotherapy, you can use single agent olaparib or a different drug called rucaparib, and this has benefited in increased progression-free survival. And I know our next speaker is going to go into more depth about what a lot of the mutations that are happening in the prostate cancer landscape. So homologous repair problems, that's again a repair of DNA. Having mutations having a mutation in one of those genes that affect that pathway can decrease your ability to improve or your ability to fix your DNA. So in this situation, we also have another drug called telaparib, and we can use that with enzalutamide. And you can see in every measurement that we have of progression-free survival and improvement that using these combinations are helpful. And then finally, we do have approval for one of the immunotherapy drugs called pembrolizumab. So Dr. Allison at MD Anderson figured out how to stimulate our immune system to recognize cancer and destroy it. And he got the Nobel Prize for this in the 2000s. And because of that work, we've developed numerous drugs like Keytruda, for certain types of cancers. Now, prostate patients have to have that microsatellite instability, again, where they're unable to repair their DNA properly. And this, you can be born with this. If you're born with this, it's called Lynch syndrome. It puts you at high risk for many cancers. It can also happen independently. The most common place that happens is in colon cancer, but occasionally be seen in prostate cancer. So we do have that therapy. Unfortunately, it doesn't work unless you have this, this type of situation. So thank you. That's I know, a lot of information and a big overview of kind of where we are in the treatment landscape. I'm so thankful, though, we have had these new drugs that have really, I think, improved the quality of life for our patients, but helping them live a lot longer. So I'd be glad to answer any questions.
Doc, once you've had the radiation treatments, how long does it last in your body?
So are you talking about the radionucleotide or like the PSMA ones?
Yeah, the PSMA one.
Yeah, I mean, I think, I'm not sure actually how long it actually stays in your body, but after, I believe, 2 to 3 days, you're not dangerous to anyone else. I don't know if Dr. Franklin knows the exact answer to that one.
I guess what I want to know is it still healing in your body after a certain period of time?
So, I mean, the thing with radiation, the nucleotides will be there. They do, right? They let off the radiation, and it does its damage there. And so it's not like it stays around, though. It's like most other drugs. It will wear off as the time goes on. Yes, then it can still have the long-term effects of it, though. Just because, let's say, even you just get a dose of radiation, the effects of it can last, though, because it's damaging those cells. So weeks later, those cells can still be dying, even though the radiation part is already done. So the effects of it last. So that's why we monitor blood cell counts even a little bit afterwards, because again, the effects can still be ongoing, even though technically the radiation part is done.
Thank you very much.
Hello. You mentioned your providers are always anxious to get new treatments online. Do you think the use of artificial intelligence is going to speed up research and bringing new treatments available?
Honestly, I do. I think what we're going to be able to do, we are just at the tip of the iceberg of being able to use artificial intelligence. And especially now we're getting so much DNA information from patients that right now part of the limitation is getting this all into a database and having something that can quickly make those connections, right, that a person's not going to see. But if you have hundreds of thousands of patients in a database with their genetic information of like what their tumor does, what treatments they've had, what their PSA response was when they progressed, and you can analyze all of that in a split second, I think it's really going to change the way we can hopefully progress cancer, I think across all cancer types. And I think we are just at the tip of the iceberg trying to figure this out. But I think that's going to be actually the next wave of real innovation. I think the last 10 years, the biggest wave in innovation for most cancers has just been immunotherapy. Our ability to harness our own immune system, that development of that, the immunotherapy drugs, the CAR Ts, like that, once you hit that kind of critical threshold, then the information goes like that. And I think we're right there now with artificial intelligence, is now that we will have these supercomputers and the ability to make these connections that, we just didn't have the power to do before. So I'm really excited to see what the future holds. Yes, I definitely think so, because that information now and the ability to build these giant, computing centers is happening, right? And we've got, and the learning that is going on is amazing. So I think it will be, hopefully in the next few years, we at least start getting some decent information out of it. All right, thank you.
We're going to take a 5-minute break, and then we'll be back in 5.